and thanks for the invite. It's a great pleasure to be able to speak tonight. I have undertaken MCG product placements for, well, somewhere over 30 years. So this will be a 20-25 minute distillation of my experience. And we'll, within it, I will the indications for MCPJ replacement, the implants available, or the types of implants available, say something about the surgical techniques and the differences between the different implants, then the results and the complications. The latter is primarily our results from Wrightington, but I will add in others as well. Okay, predominantly, as you've heard, the primary disease indicator was rheumatoid arthritis. With the decline of success, should we say, of medical treatment, this indication has declined significantly, in fact. Whilst we still undertake some surgery for rheumatoid arthritis, as I'm sure you all know, that the amount has diminished. You can also replace osteoarthritic joints and trauma, but the numbers are small, much smaller than previously. If I put it in perspective, Wrightington Hospital, we were a centre for rheumatoid surgery, and pretty much every week we would do 2 or 3 full sets of silastic MCPJ replacements. That has dropped now to less than 1 a month. So I put that in perspective. As with all joint replacements, the indications are pain, pain, and more pain. If you're going to do them for, obviously, if you do a joint replacement, you will be hopeful they would get rid of the pain, and as such improve movement and function. But if you're doing the joint replacement in a patient with little pain or no pain, who wants the replacement for improved movement and function, I'd be very cautious. If things go wrong, you may not get the movement and function and may create a painful joint. That's not to say you can't do the replacement for movement and function, primarily, but do that with care and caution. Pain is, as always, the primary indicator. There are 2 types of joint replacement at the MCP joint. There are linked, so-called silastic type implants, and the unlinked or anatomic. They do have different indications, and the surgery for them is quite different, in fact. The most famous is the Swanson replacement, which is the top there, you can see. Actually, Al Swanson came to Wrightington in 1990 and demonstrated this surgically. It's a silastic implant. Here you see grommets attached, and I'll say a bit more about that later. Further down, you'll see a modification, what was a new flex, and there are other things, which has a pre-bend of 30 degrees. The rationale for that being is that MCP joint's position of rest is 30 degrees, not full extension, which is what the Swanson was. And the theory being that that would reduce, the 30 degrees pre-bend would reduce fractures. For the anatomic or unlinked, there are various versions. This is the TMDR, which is actually manufactured in the UK, which is polyethylene stems and a metal polyethylene articular surface. But perhaps the best known is the Pyrocarbon, which you see an X-ray of it there, and I'll say a bit more about that later. The principal difference is that the linked implant or silastic, the operation is an excision arthroplasty, first and foremost. The silastic, whilst it is a foreign material and I suppose a joint replacement, if you treat it as I'll think of it as an internal splint to allow the soft tissues to heal in satisfactory alignment, that is a good surgical approach to the operation. The anatomic or unlinked are actually a true joint replacement. In these, you're relying solely on the soft tissues for stability afterwards. So you might want to say that if a joint is unstable beforehand or severely deformed, you would not consider an anatomic or unlinked implant. You'd probably go to a silastic. So those are the differences. And I'll come back a bit to that later. Okay, let's talk about the silastic joint replacement. That's the link component. Commonly used in rheumatoid arthritis, but can be used in other forms of other diseases. I'll say something about all the skin incision, extensor retinaculum capsule, etc. As you can see there, all of these, it's a sequential operation. It's an excision arthroplasty, and the silastic being put in at the end. So skinning, this is often a clinical appearance. You can see the joints here are at least the index and middle, probably the ring, the two are subluxed, if not dislocated. The little being subluxed as well. And this is the classic clinical appearance of a rheumatoid hand and MCP joint. The skin incision, there are basically two varieties. One is you can use a longitudinal incision, as you can see on the bottom right here, over each joint, or you can use a transverse incision. There is no doubt that you get a better access with a longitudinal incision, a better view of the joint, but a transverse incision leads to better healing. It's a better cosmetic outcome for the patient. And you can certainly get enough exposure to do it this way. I often extend the incision slightly distally on both the radial and ulnar aspects. As you can see, the incision is about a centimetre, maybe 7 or 8 millimetres, proximal to the MCP joint itself. And it's not over the joints themselves. With the incisions themselves, you go back to the extension. I tend to preserve the venous structures in the gullies, if I can, and then come down onto the extensor tendon. Traditionally, you'd incise on both sides of the extensor tendon. Often the tendon itself will be in the gully as part of the cause of the ulnar deviation of the fingers. So obviously at the end of the procedure, you want to move that back. So you have to release it on this side. You probably also want to release it on this side as well, on the radial side, so that you can double breast it afterwards to get it back in alignment. If the tendon is aligned and in perfect position, then maybe just an ulnar incision is appropriate. Then you can retract the tendon over to expose the joint. Some surgeons, and I don't do this, sometimes do a longitudinal incision along the length of the tendon and split the tendon. The finger joint is then exposed and you excise the metacarpal head, as you can see here. It's important to excise the whole head, and with that, the collateral ligaments. If any are left, I would release again, make sure you release the collateral ligaments on the ulnar side. As I said, this is an excision arthroplasty, and the aim of which is to realign the fingers and regain some movement. So anything that's causing a contracture, which you can see the ulnar collateral ligament, should be released. Not necessarily important to release a radial collateral ligament, although this may have to be imbricated or tightened post-op. Similar, the volar plate. Often you'll see the deformity is not only ulnar deviation, but a flexion deformity of the fingers. So a full release of the volar plate is also mandatory to allow the finger to come back up into its correct position. This is actually from Swanson's book, and really reiterates what I've just said. He was of the view that this was a spacer. The silastic is a spacer. It's not a true joint replacement. If you put it in too tight, the finger will move and the two bone ends will oppose. If it's not in straight alignment, the finger may sublux and fracture early. So again, it's a tensioning operation, a correction of deformity, which the silastic holds it or splints it in position post-operatively for a period. So this is what it looks like afterwards. I actually excise the base of the proximal phalanx. That's not original to Swanson. He didn't approve of that. You then broach the articular surfaces, and you'll all have seen these. There are trials, then true implant. These are new flex implants, which actually have the 30-degree pre-bend. These are no longer available. They're a Johnson & Johnson product. But I think there are other alternatives. And so you can see the joints going into place. And then you can see the extensions on the bottom right there, brought over and realigned by sutures to the capsule. On the index finger, it's well shown that the capsule is left open on that side. It's not possible to repair it once you replace the extensor tendon. But the fingers are nicely aligned, as you can see. With regard to the intrinsics, I think there's much debate about what to do about the intrinsics. Certainly there's intrinsic tightness. And by that I mean that if You extend the MCP joint at the end of the procedure. This is with the joint in situ. And flexion of the PIP joint is restricted, then you must do an intrinsic release on both sides. It's also for deformity. You may also wish to do an intrinsic release on the ulnar side, as it may again be contributing to the ulnar and volar displacement. I'll say a little bit more about cross-intrinsic transfer. That is a procedure that came out, wasn't Swanson, but post-Swanson, in that you move the intrinsic from the ulnar side, the index finger, ulnar side of the base of the proximal phalanx and reinsert it into the radial side of the proximal phalanx of the middle. Tricky, rather fiddly procedure, can add quite a lot to the time to the operation. Results have shown whatever you want to choose. Some have shown significant benefit, others have shown no benefit. I think it's mandatory that you have to release it, but I think transferring it is still up for debate. And I'll say a little bit more about that later, on my views on that. Okay, so remember, it is a surgical sequence, as I've just described, and it's an excision arthroplasty. I'll say a little bit more about grommets, rebalancing, I said something about, and what happens if you get an associated extensor tendon rupture. And these are grommets. They were brought out, they weren't available originally, but Swanson, reports to Swanson were of fractures and breakages of the silastic, which we're all aware of now. And they all used to break along here, really, at the junction of the distal stem with the body of the implant. This was a common site of the fracture. So he produced these metal grommets to protect these areas. And again, I'll say a bit more. Generally, they're not used nowadays, I have to say. They do tend to remain in the box. They come with every implant, but remain in the box. And again, soft tissue balancing, you can see here, this particular case, we've used anchors to restore the radial collateral ligament of the index finger. That was something Swanson made a lot about. He was of the view that if you stabilize the index finger on the radial side, either imbricating or reinserting the radial collateral ligament, this would take the deviating force off the rest of the fingers. So it was imperative in the index, but less so in the other finger. Extensor tendon rupture, it's also important to recognize that not all the pathologies can occur in many places in rheumatoid, but it doesn't always occur to the MCP joint. This flexion deformity is related not only to the deformity of the joint itself, the extensor tendon slipping off into the ulnar gullet, but also rupture of the extensor tendons. So you have to identify this preoperatively. I would recommend an ultrasound scan if you're not sure clinically. And then a procedure to reconstruct the extensor tendons at the same time of replacing and realigning the MCP joint. To emphasize that, I recently did a revision surgery. A patient sent in from a patient from elsewhere who'd had an MCP joint replacement. Unfortunately, the original surgeon missed rupture of the extensor tendon, and as a consequence, the patient had a poor outcome. The MCP joint was unable to extend the digits, despite the fact that the extensor tendon had been realigned perfectly. But once we identified this tear or rupture of the extensor tendons and reconstituted, released the MCP joints, the patient had a good outcome. Rehabilitation, again, a little bit controversial. Certainly in the first few days, patients can develop a lot of swelling after this procedure. So some rest elevation of plantage is well recommended and advisable. Traditional writing to this again comes from Swanson. It's still our practice today. Thereafter, for 6 weeks, we mobilize an extension with an outrigger. This basically allows the patient to begin flexing the joints, but retains the alignment that surgically we've reconstructed the joint to be like, the good alignment that we've obtained. And then night splintage goes on for another 6 months. In fact, another 12 weeks, or 6 weeks. Sorry. In fact, there's some evidence that night splintage for 12 months could be an advantage, but many patients find that a bit intolerable. The advantage of an outrigger, it's a classical hand surgery picture. As you can see, allows the fingers to flex, but prevents any deviation. And there's a typical paddle spin. So these are the results. I think it's easy now, it's not difficult now to perceive that the Swanson MCP joint, silastic, was a Chandler hip of its era. It was used all 6 continents of the world in large numbers, as you can see, by many authors, all reporting particularly good results. I won't ask you to read through all this. I'll summarize the results. The outcome basically is an overwhelming majority of patients are suffering with rheumatoid arthritis. Excellent pain relief, good stability, good realignment, and at the bottom there, cosmesis. Movement somewhere in the region of 30 to 60 degrees, depending on the paper, and generally improved function in the hand. And that would be a standard result. A very reproducible operation. And there's an X-ray appearance. Again, these are the new flex type joint, but again, you can see the implants well aligned. There's a clinical picture, which you can see that the longitudinal, transverse incision has healed very well. Very nicely indeed. The patient has a good functional range of motion. The student will realize that she's also had surgery to the MCP joint of the thumb, which would be a fusion of that joint. You'd often see that typically as a group of operations done together. MCP joint replacement alignment and MCP joint fusion of the thumb. Authorized particularly by Willis Suter in the UK. Okay, these are our results. We looked at, there's a thing on the left-hand side, nearly over 1,300 joints undertaken over a 15-year period. And Kaplan-Meier survival at 15 years was about approximately 70%. Not quite as good as a Charlie hip or knee, but pretty good for hand surgery. These were the reasons of revision: fracture of the implant and deformity. And then you'll probably put those together, really, because the fractured ones always went on to deformity. So about 60%, perhaps 2/3, were for fracture or deformity. Some for stiffness, which required usually an extensor posterior capsular release. And silicone synovitis, which was really the death knell for silicone in other sites of the hand, but seemed to be rarely occur at the MCP joint. The complications, our brochure infection is rare as you know, in the hand following joint replacement, which is unusual and can be treated in a silastic just by removing the implant. It is an excision arthroplasty. So at a pinch, the patient could be managed just as an excision arthroplasty rather than a silastic. Dislocation can occur and is mandatory reoperation and realignment and reinsertion of a stem of it. Stiffness I've talked about, and this together, deformity, material failure, fracture, disintegration, is a long-term complication. There you can see an image. This is from the study that we published, sponsored by Action Research. And I think we'd all agree that the implants in the little ring, and probably the middle, are fractured and causing severe deformity and requirement surgery. I think what I'd like to say is a fracture of the silasticum is not necessarily an indication for revision. Deformity would be a better indication. This is probably the only example of silicone synovitis I could find. You can see here granulomatous giant cell reaction in the proximal phalanx. Again, not necessarily a reason for revision. Well, the role of grommets. Well, this was quite surprising, actually, in our study. We compared people who had grommets to people who didn't have grommets. And as you can see, Swanson was right. The grommets actually do prevent fracture in our series. The one caveat I'd say, the fracture was identified on X-rays, and it's not particularly easy to identify a fracture in a silastic problem, which is transfers. But nevertheless, quite impressive. The only downside to this, and poorly understood, is that grommets didn't seem to have an effect on revision. That is, although there was a higher rate of fracture in patients who didn't have grommets, there was not a higher revision rate. So to date, I actually don't use grommets. I don't use them. But you could say it's still up for debate. Cross-intrinsic transfer. The position is clearer, however, that if you do a cross-intrinsic transfer, there was a higher risk of deformity and revision. In fact, predictively 6.5 times more likely to undergo revision surgery. So there does seem to be a good role for cross-intrinsic transfer. In the summary, 70% of all Swanson MCPs have survived to 15 years. That's pretty good for hand surgery. It increases further when you do a cross-intrinsic transfer. The combination of the two is quite good. The predominance for revision surgery is deformity, which all of them are due to fractured or associated with fractured implant. The role of grommets is more controversial. It certainly, or probably rather, prevents fractured implants fracturing, but doesn't necessarily reduce the need for revision. So it's a bit of a lack of clarity. Fracture rate, however, well over 2/3 of our implants were fractured on X-ray at 15 years. So it's inevitable, just it takes longer in some ones. Other things we found that if you'd had wrist surgery, and these are interesting findings, wrist surgery, wrist replacement, or wrist fusion prior to your MCPJ replacement, this resulted in a significant reduction in the likelihood of fracture. In other words, aligning the wrist joint protected MCPJ replacements long term. Detrimentally, however, if the patient had previously fused PIP joints or surgery to the MCP joint to the thumb, this had a detrimental effect on MCP joint replacement. Theories for this include that if you have had your PIP joints fused, all the movement occurs at the MCP joint for that finger, pretty much all of it. More movement leads to fracture of the silastic. If you have your thumb fused, then this would increase pinch forces across the joint, across the fingers, resulting in increased ulnar deviation of the fingers post-op. Those are theories, but they certainly have a detrimental effect on MCP joints. So again, preventive measures, attend to any wrist problems if you can after MCP. That's not to say you should operate on an asymptomatic wrist. That is always a difficult one. If you get the choice of doing wrist or MCPs, do the wrist first. And I would recommend you undertake a cross-intrinsic transfer. Okay, Pyrocarbon implant, which is probably the best and more widely used example of an unlinked implant, and certainly the one we have most experience on. Completely different mindset to do this procedure. This is unlinked, and unlike the silastic, relies totally on the soft tissues for stability. So if the soft tissues are damaged or not present beforehand, there's instability preoperatively or deformity preoperatively, then probably you should not be doing this replacement. The joint has to be stable and aligned preoperatively. You're relying totally on the soft tissue element. Pyrocarbon itself is an expensive material, as I'm sure you're aware. It's high strength, fatigue resistant, and wear resistant. It goes on forever. It's originally designed for heart valves, and these have been in for 30 or 40 years in some patients. It will not wear. There are, however, concerns, and I think probably expressed a bit more with a PIP pyrocarbon with regard to loosening, and I'll say a bit about more of that later. And really, there's very little literature on these particular implants. Okay, surgical technique. The thing to remember is, again, I can't emphasize it more, this is not an excision arthroplasty. If you go to do a pyrocarbon unlinked implant with the philosophy of doing an excision arthroplasty, it will end up in disaster. As I can tell you, and I have a patient just like that. It's nice in that it has cutting blocks, alignment and cutting blocks, jigs rather, that'll help you cut the correct amount of pulp. And again, you just need to take enough so it's perfectly balanced at the end of the procedure. These allow you to remove bone without damaging the collateral ligaments of all the plants. Again, the same would apply for the proximal phalanx. Again, all intramedullary, all alignment. To check alignment. You can use X-rays as well. Again, you can see the extensor tendon has been retracted to the other side, the collaterals are intact, and the volar plate is intact. Broaching again, You can use it, it is guided, and you can use X-rays if you wish. I know you see the implant in place. When you first see these, you wonder what these lines are around, and this is one of the difficulties of interpretation. The manufacturer, I have to say, probably misled people to begin with in saying that these implants integrate into bone. That is completely untrue. They do not integrate at all. They can sit alongside bone, and they have some biomechanical properties similar to bone, but they do not integrate. My belief is that if you get alignment correct, the perfect alignment, if you like, or pretty much perfect alignment, these implants will sit and not loosen at all. If the alignment, however, is off, maybe 5 or 10 degrees, the implant does not integrate and with time will loosen. The manufacturers will tell you this loosened zone around them, around the graphite core, and the implants, the structure is graphite. This is a graphite core with a pyrocarbon coating, and this is said to be the coating. And again, one man's coating is another man's. I guess you've got to do serial X-rays and see whether it progresses. These are our results. 51 implants, as you can see, 36 consecutive patients, older age group, pretty much all osteoarthritis, predominantly the index finger and middle finger. In fact, they were all index and middle. As I said, all osteoarthritis. Pretty good range for good pain relief and a good range of motion. Probably better than the silastic. Good grip strength, but a number of complications. I'll go through them now. Complex regional pain syndrome in 1, which was pretty unusual. Dislocation in 3 and subluxation in 1. Most of which were revised either a component change or revision to silastic. Now this is probably poor selection. Patients may well have had some deformity or instability preoperatively, or poor surgical technique. Again, I'll emphasize, patient's joint must be stable before surgery, and of course must be stable at the end of the procedure. As with all joints, stiffness is a problem, so tenolysis may be required. And stem fracture. It's unusual in the fingers, although Pyrocarbon implants have been known to fracture, particularly at the shoulder and radial head. That's fracture in the patient, the stem cracks and breaks. It is unusual in the MCPJ. An aseptic loosening, again, if the implant is not put in perfect alignment, it will toggle and eventually loosen. Survival, however, is almost 90% at 10 years, although the figures out here are very few. But at least at 7 or so, you've got good 90% survival. For that, revision being this surgery. Again, good for pain relief, good for satisfaction. Patient pleased with experience, and function and everything else improves. Radiological outcome, again, you can see the implant on the index finger here has not been put in really satisfactory alignment. And that this will undoubtedly end up loosening. And you can see subsidence in some cases, but also lucency around the implant. Again, is this pyrocarbon, as the manufacturer says, or is it true loosening? Again, it's a progressive. But some of the metacarpal and phalangeal are showing signs of lucency, increased lucency, again related to malalignment. So it does seem to be a good procedure. It's a difficult procedure, far more difficult and certainly different than putting a silastic in place. Gives good pain relief, good functional grip, and implant survival. Patients can be very satisfied after this procedure. For discussion, well, again, I think happy to take questions on surgical technique and stability. I think pre-op assessment of the patient is crucial. And again, I won't go over it again, but I hope you've got that. Loosening, again, for pyrocarbon, it will be progressive if the implant's not put in correct alignment. If you're happy with putting in correct alignment, and again, check on X-ray at surgery, then I think you've got a good long-term result. Again, there aren't particularly good long-term follow-ups of this. These are the studies that have been done to date. I think I would refer you to the left. Pretty good follow-up on many of these studies, again, in the short term. Numbers, however, going forward will always be small. It's pretty much limited to osteoarthritis, possibly fracture. Thank you for your attention.